Hi, I'm Caitlin Erie from Boise, Idaho, and I will be discussing a case presentation highlighting the Arthrex lateral tibiotalar arthrodesis plate in the setting of an ankle fusion. The patient is a pleasant 48-year-old female who presented to clinic with complaints of right ankle pain and deformity. She had a history of a right trimalleolar ankle fracture that was treated operatively in another city approximately a few months prior. She admitted to being fairly non-compliant post-operatively with her weight-bearing restrictions and had experienced progressive ankle pain and deformity over the past few months. Unfortunately, her pain and deformity had progressed to the point where she was becoming minimally ambulatory. She had a past medical history significant for multiple mental health issues, as well as seizure disorder, substance abuse, and obesity. On physical exam, the patient had obvious valgus hindfoot malalignment. She had tenderness to palpation anteriorly over the ankle and pain with attempted range of motion. She had early signs of skin tenting at the medial aspect of the ankle secondary to her deformity. She otherwise had full strength and sensation throughout. She was grossly neurovascularly intact distally and did not have any signs of peripheral neuropathy. I was able to obtain her immediate postoperative images from her previous surgeon, in which she had continued subtle lateral translation of her talus, malalignment of her mortise, and likely non-anatomic reduction of her fracture. When she presented to my clinic approximately 3 months later, she had developed obvious displacement of her fracture, hardware failure, and valgus collapse through her ankle. I obtained a CT scan to further evaluate the extent of arthritis within her tibiotalar joint. The CT confirmed the presence of fairly significant cartilage wear and bone loss at the lateral aspect of her joint. At that point in time, I had a long discussion with the patient in which options were discussed. In terms of surgery, we discussed a revision joint sparing type procedure versus arthrodesis. We discussed surgical options in clinic, including revision open reduction internal fixation of her ankle versus proceeding with fusion. In order to avoid chronic pain and recurrence of deformity, the patient elected to proceed with a fusion. When considering approaches for an ankle fusion, I elected to approach her ankle through a lateral approach. I essentially did this for two separate reasons. The first was to utilize her previous lateral incision, both for her hardware removal and for her ankle fusion. I felt that it would be advantageous to do all of the work through a single incision. I also elected to proceed with a lateral ankle fusion in order to allow the plate to essentially act as a buttress to prevent recurrent valgus collapse of her ankle. As we know, this is an inherent tendency following this type of injury. The patient presented back to clinic 6 months postoperatively and overall was doing incredibly well. She appeared to have completed her fusion on radiographs and was essentially pain-free. She had returned to full activity and was overall happy with the outcome of her surgery. In terms of my postoperative protocol, I kept her splinted and non-weight-bearing for the first 2 weeks. She returned to clinic 2 weeks out from surgery and was placed into a short leg cast. She remained non-weight-bearing from week 2 to week 6 and presented back to clinic where a new short leg cast was applied. I then allowed her to weight bear for transfers and short distances only, and at 12 weeks postoperatively, she was transitioned from a cast into a cam boot and was allowed to start being weight-bearing as tolerated. She also weaned the boot as her ankle allowed. Most patients following this type of procedure return to full activities around 4 to 6 months postoperatively. The Arthrex ankle fusion plate has a very well thought out design taking in key considerations when approaching an ankle fusion. The plate has an anatomic contour that allows the plate to sit flush against the lateral aspect of the distal tibia and talus. There are also multiple options for compression across the joint, including an oblong hole at the proximal aspect of the plate, as well as an anatomic compression hole at the mid portion of the plate. Finally, the plate allows for divergent fixation within the talus, thus increasing the strength of the construct. When approaching an ankle fusion through a lateral approach, I have found a few general indications in which I think having a lateral ankle fusion plate available is very helpful. The first situation is in the setting of a poor anterior soft tissue envelope, in which any anterior incision would place the patient at high risk for wound or other soft tissue-related complications. The second indication is when a lateral incision is already required as part of the procedure. This may be the case in the setting of fibular deformity, where the deformity must be corrected prior to ankle reduction and fusion. This may also be the case, such as in this case presentation, where there is already retained hardware at the lateral aspect of the ankle that must be removed prior to fusion. Finally, I have found this plate to be helpful in the setting of a significant valgus deformity at the ankle. The plate helps to provide a buttress against recurrent valgus deformity, which we know is a risk following this type of deformity. Thank you.